Now we will talk about the second part of the lecture, which is the preoperative preparations of the cesarean section. First, you have to see the couple and explain to them and the gaining and consent of them from them. You should explain the complication, the preparation, the post-operative risk. All information about cesarean section should be mentioned to the couple, both of them, and then if they agree, you should take an informed written consent. You should send for blood group and you should send for cross-match blood, and this is a preparation because in case of any time you have a bleeding, you can ask for this blood. You have to have good or normal hemoglobin level prior to operation. You should discuss with your patient and counsel the anesthetist for the type of anesthesia, and you can catheterize the bladder in cases, for example, in every patient with spinal anesthesia and in patients with a previous cesarean section, or any woman you need to monitor her urine output, or you should need to check if there is risk or you suspect risk of adhesion in the surgery. Thromboprophylaxis according to the risk factor for the woman. Prophylactic antibiotic before the skin incision to decrease the risk of infection, and sometimes you need to give sodium citrate 20 ml or metoclopramide or with it in order to avoid vomiting during the anesthesia, and which may result in chemical pneumonitis. Also, you should advise your patient if she had an elective surgery to be fasting for 6 to 8 hours. Postnatal care or postoperative care, your duty is to check the vital signs and blood loss, especially vaginal blood loss, in order to catch any risk of postpartum hemorrhage. And sometimes you should monitor this patient for example every 15 minutes or every 30 minutes according to the instruction of the senior doctor. You should examine for the uterine fundus and feel it if it is contracted or not, and if it is in the normal level at the umbilicus. Also, you should check the consciousness of the female post-operatively and the oxygenation status. It is not mentioned here. And you can provide good parenteral analgesia and IV fluid in the first few hours, especially in the first 8 to 10 hours post-operatively, because the woman is not taking oral feeding in that period. You can remove the urinary catheter once the woman can mobile and can gain her mobility, especially after regional anesthesia, and not sooner than 12 hours after last epidural top-up dose. You should encourage for early mobilization. This helps to decrease the incidence of DVT. Also, you should ask or instruct your patient to take a deep breath, and you encourage her to cough if she had any sputum or if she had any risk of atelectasis of the lung. You should care for the wound and look at it if there is any bleeding or risk of infection. You can change the dressing after in the second day. Also, advise the woman to start breastfeeding as early as possible if there is no contraindication for it. You should give also prophylaxis or continue prophylaxis thromboembolism in risky patients. And the length of the hospital stay normally is about 3 days for the cesarean section ideally, but because our hospitals have overloaded, you can discharge her in the next day or a day after it. Especially the first 24 hours is the first important hours to be followed in order to avoid complication. The complication of cesarean section, we had immediate complication, for example postpartum hemorrhage, which may need emergency hysterectomy sometimes if you did not control it intraoperatively or in the first few hours post-operatively. Bladder or ureteric or bowel injury, as we mentioned, if she had any adhesions. Intra-abdominal hemorrhage also is important, so that's why we should check vital signs post-operatively and abdominal distension. Anesthetic complication as any other operation. Wound hematoma can also occur, and neonatal transient tachypnea. and sometimes fetal injury. If you do an incision, uncontrolled incision, you can injure the body of the fetus. Intermediate complication: after 3 days, the woman may experience paralytic ileus or infection of the uterus, of the urinary tract, or pulmonary infection, for example, due to atelectasis, chest infection can superimposed, DVT and pulmonary embolism. And late complication, for example, she may have subfertility due to adhesions of the tube and blockage of it, vesicovaginal fistula by surgical incision iatrogically if I did not catch the incision, the injury, and there is adhesion in the lower uterine segment. Placenta previa or accreta can occur usually in the second successive pregnancy. Any scarred uterus is a risk for placenta previa and placenta accreta. Scar rupture can occur in successive pregnancy, so any woman with a previous uterine cesarean section, she is at risk in her second or successive pregnancy to have risk of rupture of cesarean section scar. Antepartum stillbirth in next pregnancy can also increase. Now we'll talk about episiotomy. Episiotomy is a surgical incision of the perineum. It is made to increase the diameter of vulval outlet during childbirth. The WHO recommend about 10% rate for episiotomy in normal labor. Techniques: we have two types of incisions. We have either midline, we cut it vertically from the posterior fourchette down towards the anus, or mediolateral, which is start in the midline and then turned laterally, directly laterally, in order to avoid the anal sphincter. The benefit of episiotomy is the prevention of perineal laceration by anatomical incision and repair of the episiotomy. Prevention of prolonged and overstretch of the perineum, which predispose to prolapse and stress incontinence in future. Minimizing compression and decompression of the head, which causes intracranial hemorrhage. This picture shows to you the two types of episiotomy incision. This is the midline. We started from posterior fourchette of the vagina toward midline toward the anus, but we should avoid reaching the anus in order not to cause trauma or tear to it and we have successive incontinence. Once crowning occurs, we infiltrate the area with local anesthetic medication, xylocaine normally 10 cc, and then we cut it. Or nowadays it's better to start in the midline and then directed laterally in order to avoid the incision towards the anus. The advantage of the midline episiotomy: it has less blood, easy to repair, heal quickly, and less pain in postpartum period with less dyspareunia. The major disadvantage, as we mentioned, is the extension into the anal sphincter and causes 3rd or 4th degree perineal tear, and this is more in midline incision and can have a complication of fecal incontinence. If you have, as we mentioned, if you have decided to do episiotomy, you should provide an infiltration with local anesthesia. The indications for episiotomy are fetal distress. I want to deliver the baby rapidly, so I will do episiotomy. If you have short or inelastic perineum, if there is shoulder dystocia because of manipulation steps, I need generous episiotomy. Fetal malposition, for example, in occiput posterior and in any instrumental or breech delivery. If the woman has a previous pelvic floor surgery for repairing of the pelvic floor, I should do episiotomy in order to avoid injury and recurrence of vaginal prolapse. The complication in the lateral episiotomy: it is more painful, more complicated to be sutured, more risk of bleeding, and the extension to 3rd or 4th degree perineal tear is less, as mentioned, compared to the midline, but it can happen. Bleeding, as we mentioned, because we open into the muscle area, and infection, so prophylactic antibiotic is given. Now the recommendation is to use mediolateral episiotomy, but also must begin in the midline and then directed to the laterally. We should start the repair about 1 centimeter above the apex in the vagina at the level of the incision of the episiotomy, and continue continuously to the level of the vaginal opening. At the opening of the vagina, it's bring together and suturing of the sorry, suturing of the muscle and the deep part of the incision, and the vaginal opening then or incision is sutured. This is picture shows to you the episiotomy shape, and we start as we mentioned in the apex, above 1 centimeter above the apex, deep in the vagina, and suture it till you reach the vaginal opening. Then you suture the deepest part of the incision like this till you reach to the incision. You suture it externally. And thank you. I'm ready to answer any question if you need.